Hey, good morning, everybody. We're going to go ahead and get started. Jill Blumenthal is not here this morning, so she asked us to just briefly introduce ourselves. I'm Lucy Horton. I'm one of the infectious disease fellows here, and I've been helping out with this migrant shelter project since kind of the new year. And this is Linda Hill.
Lucy's being very modest. She's done more than help. She's been absolutely indispensable. I would not be alive today without her. I'm a professor in the Department of Family Medicine and Public Health, and I'm the director of the Preventive Medicine Residency at UCSD and the director of the Refugee Health Assessment Program, which is how I got roped into this project.
So the title of our talk is the Development and Implementation of a Health Screening and Management Program for Asylum Seekers at the US-Mexico border. And neither of us have any disclosures to report. So in a brief outline of our talk, we're going to give an introduction to asylum seekers and the local San Diego response. Linda's going to give us kind of a personal story about how UCSD became involved in this project, and an overview of the health screening program. We'll discuss some of the public health protocol development, summary of program impact. Sure.
And then discuss some lessons learned and future challenges. So just a brief background on refugees and asylum seekers. So around the world, the UN Human Rights Report reports that a total of 68.5 million forcibly displaced people, to 25.4 million refugees and 31 million asylum seekers currently exist in the world. And what's interesting is that actually the majority of these displaced people are actually hosted in developing countries. So although a lot of us kind of have this perception that the US takes, a big majority of refugees, that's actually not the case. And the top refugee hosting countries are Turkey, Uganda, Pakistan, Lebanon, and Iran. However, San Ysidro is the busiest port of entry in the Western Hemisphere. And last year, there were 18.8 million pedestrians that went through at the 6 border crossings in California, and the majority of those were in San Ysidro. And if you combine San Ysidro and Otay Mesa, you can see that our area takes in most of the border crossings in the Western Hemisphere. So overall, the number of migrants crossing at the southern border without authorization remains dramatically lower than in the past, although there has been a slight increase recently. So in the early 2000s, the number of apprehensions at the border peaked at about 1.6 million per year. By last year, there were fewer than 400,000. And this change is actually mostly due to changes coming from Mexico. So better economic system in Mexico, more job opportunities, and that's resulted in fewer Mexican migrants crossing the border looking for work. There's also been an increase in border security in the post 9/11 era. But what has changed in the past several years is the type of migrants that are coming to the southern border. So previously, they were mostly young Mexican men who are seeking employment, either temporary or permanent, in the US. But now more than half of them are from the Northern Triangle countries of El Salvador, Guatemala, and Honduras. And since 2012, there's been a big increase in the number of unaccompanied minors and families from this area. And they're now estimated to be greater than 60% of the total. And these are just 2 pictures from the Northern Triangle region, kind of just showing some of the hardships that people are facing, homeless people, eating on the street, living on the street. And so when we talk about the border crisis, what does this really mean? And I found this quotation from a Stanford University professor, Lucas Gutentag, who's an immigration law expert. And I think he summed it up well when he said that the crisis at the border is not the numbers who are arriving, but the system's failure to respond in a humane, efficient, and orderly way in light of the government's legal obligations and the number of migrants who are seeking protection. These migrants coming from Central America are fleeing almost unprecedented levels of violence and danger from countries that have some of the highest gang violence and murder rates in the world. Yes.
So the government's obligation, or is it the US government or the local government from where the countries from where these people are coming?
The US government.
So what is the US government's legal obligation towards the migrants or immigrants?
So you're going to mention this briefly. Yeah, sorry, we'll get back to that. And just a quick overview of the asylum process. So to gain entrance as an asylum seeker, individuals present themselves to CBP, which is the Customs and Border Protection Agency. And in our recent experience, it seems that only adults who are traveling with children or pregnant women and who have a family member or friend to sponsor them here in the United States are the ones that are being admitted. And then if chosen for interviews, the asylum seekers are brought to the CBP facilities where they undergo a background check, they're assigned a court date, and they're released with a detector bracelet on their ankle, basically like people who are on patrol get. And if they're lucky, they're given permission to wait for the court date here in the US, and then in the location that their sponsor is. So asylum seekers have been presenting to CBP for years. And since 2009, the Immigration and Customs Enforcement, or ICE, has helped these asylum seekers get to the destinations of their sponsors through something called the Safe Release Program. So they help them with phone calls to their sponsors and transportation arrangements as well, either by bus or by plane. However, in November of this past year, ICE abruptly stopped this service and instead just began dropping people off in San Ysidro and other port of entry cities at parks, at bus stops, and other public places without really any way to get to their sponsor, no financial assistance. Often people don't even know what city they're in or what state they're in. This has created a huge problem. And so the San Diego Rapid Response Network was really the first group to, step in and deal with the situation at the end of the Safe Release Program. And they're a group of nonprofits with a mission to help immigrants, refugees, and asylum seekers. And when the Safe Release Program ended in November, Rapid Response started just collecting people from public areas and bringing them to safe places. They would literally like drive around in San Ysidro, picking up people from McDonald's, people who looked lost, who looked vulnerable. Jewish Family Services, which is part of the Rapid Response Network, started a shelter in San Diego. And it was first located at a Catholic church in Imperial Beach. And they worked in collaboration with some of the community health partners, La Maestra Health Clinic and San Ysidro Health Clinic, to provide medical care in mobile vans behind the church. The Jewish Family Services staff and volunteers were the ones that were helping with travel arrangements, shelter, clothing, food, etc. However, the tragic deaths of 2 children in U.S. custody at the end of 2018 really led to increased scrutiny of the Department of Homeland Security procedures and brought, a lot of attention to the end of the Safe Release Program. So Jacqueline Kyle was a 7-year-old boy who died in El Paso on December 8th from dehydration, shock, and liver failure. And an autopsy report that came out in March confirmed that he died of sepsis. And then Felipe Gomez Alonza, an 8-year-old, died on December 24th in New Mexico from influenza B after he and his father spent 6 days in a crowded Border Patrol holding cell. So following these events, on December 22nd, Department of Homeland Security asked that the San Diego County Health Department expand its efforts. So previously, they were just doing informal screening by non-medical personnel, and then they had the intermittent backup access to the public health care facilities, like the San Ysidro Family Center, but there was nothing formal in place to screen all the migrants. It was really just kind of like an urgent care situation. And the county turned to Linda and asked her if she could help organize these efforts immediately. So I'm going to turn it over to Linda.
So I'm going to start, I'm kind of going off slides at this point, and I'm just going to give you a little bit more political background because I think it's really important here. And my disclaimer is that I'm neither a historian nor a political scientist. I am a bleeding heart liberal, but that I'm hoping to give you a story that has truthiness. So people ask me why Guatemalans and Hondurans are seeking entry into the United States, and are these economic asylum seekers? And the answer is no. They're fleeing just unspeakable violence in their countries, near anarchy. The gangs in the Northern Triangle rule the country. The gangs are armed, and they wield their power through intimidation, extortion, drug trafficking, forced recruitment into gangs. They have child soldiers that they've recruited, and then they get on drugs. The largest gangs you may have heard of, MS-13 and M-18 or Barrio 18, started in LA, and then the gang members were deported back to the Northern Triangle and had access to arms. The police are reported to be bribed by the tens of thousands of active gangs. Something like 40,000 gangs are roaming not just the cities, but the countrysides and the small villages. Guatemala has a history of sexual assault and killings against the populations of Mayan descent, and the Guatemalan Civil War ended up in 200,000 casualties. Sadly, the U.S. shares a fair amount of responsibility for the political unrest in this region. In the 80s, the Guatemalan military was massacring indigenous Guatemalans. This was known to the State Department, and they were funding and providing arms to this region with the intent of stopping the spread of communism. A UN Truth Commission in 1999 said the US bore much responsibility for advising, training, arming, and financing the troops, even teaching torture as part of the Reagan administration's campaign against communism. In the Civil War, it was the US-backed military who committed 93% of the atrocities, and now it's the unchecked large number of roving gangs. The New York Times reported on April 5th last month that women are being particularly targeted, with reports of women being raped, shot, skinned alive, often in front of their children. At the same time, President Trump tweeted late March he would cut off aid to Guatemala, Honduras, and El Salvador. However, a vast majority of the aid goes to non-governmental organizations, churches, charities, and private contractors to improve security and justice systems to prevent violence. So these residents of the violent Northern Triangle, including El Salvador, are seeking safe haven, and the groups traveling north from this region are referred to in the media as the migrant caravan. So as Lucy said, the people have been seeking asylum for many years and presenting to Customs and Border Patrol, and they had this system of safe release, helping people get to a safe place, because if they're just released to the community, they have no way of getting themselves into a safe space. So the county called me. So the next part of this story is about a public health response to the humanitarian crisis that was created by the large number of people seeking asylum, and CBP stopping the safe release program. And then, as Lucy said, the death of the 2 children, prompting DHS to say that it was no longer acceptable for people to be released by ICE into the community, and that some kind of systematic screening had to be done to make sure people were safe. The other lesson in this story, and I'll tell you the lesson ahead of time, is that sometimes the system works. And UCSD actually really came together for me. It's quite remarkable. So the county did call me on Friday the 21st. I have a half-time practice in a community health center where UCSD rents me to a community clinic in Linda Vista, actually where Mary Caffrey and I met in 1980, which dates us both a little bit. And they told me that I had 72 hours to start a program on Christmas Eve that would screen people dropped off 7 days a week, starting at 3 p.m. every day. So the mission and directive was to screen and manage all the asylum seekers who were entering the shelter being run by Jewish Family Services for acute illness, mainly infectious diseases. And in order to both protect them, the individual, and make sure they were safe, and to protect the public, because people were then going into a shelter where they were sleeping with, up to 160 people. And the shelter was in a building owned by Catholic Charities. It was looked like an old community center, and it had sort of a auditorium-like room with a stage in the front, and it was cut, like this. And then some smaller rooms at the side, which we ended up using as scabies isolation rooms or other kinds of isolation rooms. So the last words I remember hearing from the county was that it would be, maybe 30 people a day, and they'd come at 3 o'clock. So the reason that I got tagged is that I already had a contract with the county to do a refugee health assessment program. So all newly arrived refugees to San Diego County go through an assessment program, much more comprehensive actually than what was being asked for with the asylum seekers, where we screen for with blood work, stool, and skin testing or quantiferon for multiple infectious diseases. It's a 2-part exam. It's a more comprehensive assessment. And we've been doing this for 10 years. Prior to an event that happened on January 21st, 2017, we were, think for a minute, what happened on that day? We were the largest refugee health assessment program in the country, seeing over 3,000 people a day, 3,000 refugees being admitted to San Diego County and being managed by the refugee health assessment, the refugee resettlement agencies, Catholic Charities, Jewish Family Services, International Rescue Committee, who were bringing people in, bringing them through this program and getting them, housing, jobs, ESL, and so on. Currently, we're less than 300 a year, where our program's been cut 90%. So it doesn't say that in the news. It doesn't say that. We're seeing less than 10% of the, in terms of your question about what's the United States doing for the refugee crisis across the world, we're doing much less than we used to. Again, maybe a little bit more of a political talk than you usually get at Grand Rounds on a Friday morning, but it's hard to talk about this without talking politics. So, yeah. A year.
Where was that funding coming
from? From the,
federal, state, or county?
so from the feds,
Okay.
from the Office of Refugee Affairs to the state, And then the state distributed it to all the counties to run this program. So across the country, multiple refugee resettlement agencies were managing these programs. And now there's just been massive layoffs. Many are closing offices in cities. This is, another story, but there was a robust and very effective system of refugee management. So again, some of this is going to sound like hyperbole, but I just want to give a shout out to UCSD when the system works. So the county added one sentence to my contract for refugees saying, refugees and asylum seekers will get medical. So that's why they were able to send me a contract on such short notice. So that contract arrived on Christmas Eve on my inbox. And I was supposed to start at 3:00, but what happened was I have a wonderful department chair, Cheryl Anderson, and a wonderful business office lead, Randy Brooks, and they called the head of contracts and grants, Jean Hagasawa, and said, we need you to sign a contract. Yeah, it's Christmas Eve, but they got hold of him. He signed it. At 2:55, the signed contract comes into my box, and I walked into the shelter. So like sometimes it works. Sometimes people just, yeah. So I mobilized our refugee health team, which was Kathy Fisher, Ryan Moran, Camila Romero, who's here, and my colleagues and friends, including Lucy, who had reached out to us to help in the refugee clinic, and then eventually Joe came on board. We were able to quickly call over the Christmas holidays residencies and say, just start sending us your people. We didn't have enough people. The business office was closed. We hadn't hired any extra doctors. People started coming down sort of on the promise that we'll, work now, we'll pay you later, we'll figure it out.
Learned a lot. It was just the way
Well,
our academic system works. Right?
It was so nice.
Came in and did a lot of work.
They did a lot of work.
A lot out of it, actually.
And it wasn't actually great conditions at those first 3 months. It was, as you recall, a rather rainy winter. And the way that it was set up was that the asylum seekers were coming into a courtyard and being put under kind of open air tents. And then we were sometimes seeing people outside at tables and sometimes in a vestibule that led to another office. And eventually the county drove up their STD mobile education van in front of the shelter, and two groups could fit in that rather cramped space, but it required a generator, a noisy generator. That first week, my husband went to Costco and picked up space heaters and lamps. We didn't have outdoor lamps. We needed tables. We needed thermometers. And he's checking out at Costco. He looked like a survivalist, with all this stuff. So what we realized early on is that we needed to standardize intake. We needed to all be doing the same thing. So we very quickly came up with, the questions you'd want to ask if you were screening for TB and lice and scabies and flu and other infectious diseases. What would you ask? And then, really limited vital signs. We pretty much restricted it to temperature. And then, a screening form for the physicians. And then pretty soon we had to develop protocols, which Lucy's going to show you, which ended up being very much of a joint effort with the county, and the county expertise was really invaluable. I'm going to talk a little bit about the challenges, but I know there's wonderful advantages to working with a group because you get all this pooled expertise, and then the disadvantages, like decision by committee, had to go through a lot of approval processes before we could implement. The other challenge was that people did not, as it turned out, 30 wasn't the number that we were seeing. And our range of arrivals has ranged from 10, our very lowest day, to 270 a day. And they didn't come in, it's not like a clinic where people just come in. They come on an ICE bus and 50 people get off the bus and then came to us for screening. The good news was that once UCSD opened for business again, we were able to actually hire people and bring them on, and we were able to sort of get through that. I have just some pictures that we got off the internet just to show you some of the gang tattoos and then some of the faces of the asylum seekers en route. And then this is a series that were taken at our first shelter. It was just amazing, the resiliency of the kids who just picked up a soccer ball and started playing in the courtyard. And then ICE takes away people's shoelaces. So they don't want them to harm themselves with shoelaces. So we had JFS bought a lot of shoelaces to replace their shoelaces, and then you have this picture as well. And then here's an example on the upper left of what the sleeping arrangements look like. Now, the good news is that on the upper right, on April 6th, we moved to the old family courthouse. It's going to be torn down at the end of the year. So the County Board of Supervisors fortunately voted to rent for $1 to Jewish Family Services the old family courthouse. They then raised money to put, I would say, hundreds of thousands of dollars of renovations into it, because they had to, it was not habitable, and they had to have places for people to sleep and eat and so on. It's still planned to be torn down, and it's not clear what will happen after that. JFS acts like a travel agency, where after we finish screening, that's their next stop, and they get on the phone with sponsors immediately and say, I've got your relative here. Can you pick them up at the bus stop, tomorrow at noon? Or we're putting them on a plane, and can you meet the plane? And that happens immediately. Sometimes that happens before we see them. They start walking around the rows of people and getting their phone numbers and start calling their sponsors. Yeah, sometimes they do a lot of fundraising around this. Yeah, they are amazing. So here's some of the clothing, and people arrive with just sometimes just a small plastic bag of personal possessions, and then here's some more pictures that Lucy took of we have a map of where everybody's gone as well. So I'm going to turn it back over.
Great, thank you. So just a little more details about the program. So what is the role of the county and the UCSD contracted staff? As Linda said, it's really to do the health screening assessments. So to screen and evaluate the asylum seekers, really for diseases of public health importance. So mainly communicable diseases. Treat and refer for any conditions that are encountered, and then transfer the newly arriving guests either to the general population shelter, where they stay usually for anywhere between 12 and 72 hours before leaving to travel to their sponsors. Or if necessary, isolate and refer them to a higher level of care depending on the conditions encountered. The county's also been involved in some kind of non-health related projects. They've done food safety assessments. That's with the Department of Environmental Health. Coordination of a daily report, and then epidemiology support and follow-up. And they've also supplied the nursing. So all the nurses that are involved in this program are county public health nurses. And this is just kind of a schema that the county put together to explain the program. So the services are provided every single day of the week from 2:30 p.m. to 11 p.m., and that includes all weekends and holidays. And initially, there's the health screening assessment. So there's usually 3 nurses that conduct this. And then they're supported with ancillary staff, which are either county staff or contracted interpreters who help with some of the paperwork, filling out HIPAA forms, doing translation, really just extra hands on deck as well. There's one county physician or logistics administrator, and they're usually on call, so they're not actually on site, but they're available by phone for any consultation and help with logistics coordination. And then there's standby nurses from the county as well that can be called in at short notice. And then the follow-up health screening, treatment, and referral is what's done by the UCSD contracted staff. So we have both nursing staff and contracted physicians, about 2 to 4 per night on average, that provide the medical evaluation and follow-up. So on average, there's about 14 staff members per day at the shelter. And so there, the personnel is really coming from a variety of different partners. And so every day there's different people from different agencies all coming together and working as a team. There's never the same group of people there every day. So there's the Rapid Response Network and JFS shelter staff, and they have a lead every single night, and that rotates. From the UCSD side, Linda, Kathy, and then Gina Fleming as well as directors. There's a group of about 10, I'd say, lead physicians there's 1 lead physician per night. Carmen Cutter and Carrie Guerra help with organization. From the county side, Jennifer Tudor, Susanna Graves, former ID fellow, Denise Foster are the leads, and then the team of public health nurses. And then just a ton of physicians, PAs, NPs, medical residents from all across. Yeah. Sure. So we actually touched on that at the beginning. It's a group of organizations in the San Diego area whose mission is to help with refugees, asylum seekers, and immigration rights. And it's a group of nonprofits that's kind of under the umbrella of the Rapid Response Network. And when the Safe Release program got cut by ICE in November, Rapid Response came in and kind of picked it up. Sure. So quickly, I'm just going to go through some of the screening protocols for you to see. I think it's interesting to see how they've been developed and modified to fit the specific needs of the shelter. So all the guests come in, they get an initial health screening assessment. And this includes a screening for specific symptoms, a brief medical history. We ask about medications. They get an oral temperature, hair, and skin check, pregnancy test if indicated. And this is completed by one of the public health nurses with auxiliary staff interview. So this is the screening form, page 1 and page 2. So on the left is the part that the public health nurse fills out and screens. And then after that's completed, they get sent to the physicians. The physician fills out the second page. So reviews the screening, does a kind of brief or targeted physical exam, and then assesses the patient. And this is our shelter disposition and referral form. And so this is the protocol that was developed to standardize how patients who need to be referred to either a public health clinic, the ER, or need to be isolated for one of the isolatable conditions. They get one of these forms filled out. One goes to the shelter staff. One is sent with the patient if they need to go to the emergency room as a means of tracking the patient and keeping a record. And so, one of the issues that came up was the need to standardize protocols for some of the issues of concern. So everyone, at or everyone involved knew how to treat communicable diseases like lice, scabies, varicella, et cetera. But nobody had done this in the setting of a shelter where people are sleeping in large rooms of over 160 people with beds inches apart from each other. And so the isolation procedures and best treatments really had to be determined for this unique situation. And the protocols were developed in collaboration with the County Health Department and the UCSD Refugee Health Program, also with input from the shelter staff at JFS. And the goal was that they're evidence-based and easy to follow. And they've now been produced for a variety of diseases, and to date include specific protocols for lice, scabies, influenza-like illness, gastroenteritis, pregnancy, tuberculosis rollout, mumps, varicella, and measles. I'm just going to go through 3 of them. So the Scabies Protocol, the main challenge was finding an isolation location to house the infected guests. So when the shelter population was lower, maybe only like 30 to 40 guests, it was easy to use a spare sleeping room. But once the census grew and all the beds needed to be used for shelter guests, the families ended up getting sent to a local hotel. And initially, permethrin was being used, but it was pretty difficult to use creams in a facility with limited shower access, where people would be waiting hours and hours to shower, and they'd just be kind of standing there covered in permethrin cream. Also, once they were sent to the hotel, the issue with the cream was that you'd have to explain to them how to apply the cream and then kind of, just hope that they would apply it correctly. So we changed the preferred treatment to ivermectin for most cases. It's also easier to treat family members. You can do directly observed therapy, so ivermectin seemed like a better choice. With regards to treatment of family members, there's no set guidelines on whether to treat family members who don't have visible lesions, so it's left to the discretion of the providers. And so this is just the protocol. So if they complain of a rash at the time of the initial screening, then we, do a more thorough skin exam and treat them with ivermectin unless they do not meet the minimum weight requirement, and then they will still get the permethrin, and then they're isolated. And they get their clothing gets discarded and they get fresh clothing to put on after the treatment. Example 2 is the pregnancy protocol. So pregnant women can't be universally restricted from travel after 36 weeks of gestation, although this is what's recommended by the OBGYN societies. And why is this? Well, there's really complex family, cultural, and financial considerations for each pregnant woman. And, they need to get to their sponsors because they might have a court date coming up. Culturally, it's maybe not acceptable for a single pregnant woman to be staying by herself. She can't afford to be staying on her own without her sponsor. So she still needs to travel to get to her family. A lot of the women have not received any prenatal care, or maybe they've just received sporadic care in Mexico, but they don't really have any medical records. So they would self-report, oh, I think I got an ultrasound and they said everything was fine, but we have no record of that. So the protocol was developed to screen for high-risk pregnancies and complications with aggressive management for modest blood pressure elevations. So pregnancy testing is offered to all women who either don't know their pregnancy status and their menstrual period is delayed by at least 2 weeks. And so all women get asked when their last menstrual period was as part of the screening assessment. Then the lead nurse will test them if necessary and then refer to the physician, where we'll ask additional questions to screen for complications and measure the blood pressure. If blood pressure is elevated or they do have positive symptoms, then they get referred to the emergency department for further assessment.
So just to jump in here, this is a really aggressive pregnancy protocol, sending pregnant women, maybe just 12 weeks pregnant with an elevated blood pressure to the emergency room. But we talked this over with you know, our OBGYN colleagues here and elsewhere, and also talking it over with the county. This is an unusual, again, this is what Lucy's saying. You know, we all know how to treat pregnancy, you know, to some extent, but we've never treated it in this kind of a population where people haven't had care, and then they're leaving us. They're leaving us to go, we don't know where and what kind of care they'll get. So it is an unusual and extremely kind of aggressive approach, but it's better safe than sorry. And some of the decisions that we make, so I kind of, it's like being a lifeguard in a way. You have this really high volume, generally safe, you're watching everybody, keeping track of them, but there's the potential for something really bad to happen. And so you have to constantly stay vigilant and maybe do things that you wouldn't do, because I don't want anybody to, you know, die on our watch. This is very high stakes, not just from a humanitarian point of view, but from a political point of view too. So there, sometimes I mean, you've been very kind, but sometimes they're odd protocols.
And then I'm just going to mention that a measles protocol is still in development, but about to go live. And this is really because all of the measles outbreaks across the country have kind of prompted the need for a shelter-specific protocol, given that measles is highly contagious and transmission and outbreak in a high-density setting in a transitory and mobile population is, you know, very concerning. And the vaccine status of the asylum seekers is often unknown. People just know that they've had shots. They don't have vaccine records. And so we have to be particularly careful. And also, I should note that the guests are in close contact often with shelter staff and volunteers who are not from the medical side. And although all medical workers have to have, you know, immunity to go into a healthcare setting, the shelter staff and volunteers may not necessarily have known immunity, so we have to protect them as well. And so, you know, I think the measles protocol is probably pretty similar to that of other healthcare facilities, but, you know, we would immediately mask and isolate anyone with a fever and maculopapular rash until they can be assessed by a physician. And then we would immediately report the case and isolate them offsite. So impact of the program. So as of Wednesday, there had been 11,188 total screenings since the program started at the end of December. And, you know, as Linda mentioned, the numbers per night vary from 10 to over 200. But the average per day is 77. And you can see that, you know, it goes high, it goes low, and really for reasons that nobody's been able to figure out. There's a lot of theories, most of them are political, but the numbers sent every night are, you know, your odds are better at winning the lottery than guessing how many are going to come each night.
So one of the things that has driven our numbers down in the last few weeks is that Trump came out and said asylum seekers have to wait in Mexico, so they can come here and get assessed by CBP, but then they have to wait in Mexico. So a lower court threw it out and said that's unconstitutional. We allow asylum seekers to wait in the country. That's their right. Then a higher court, the next higher court, that unfortunately one of the political parties is starting to get control of the courts, that they then backed up Trump. So we saw a big drop. But just to show you how volatile this project is and how the politics are weighing in on it, while we've been here, somebody's been texting me, the county's been texting me that Texas is, as we speak, flying people to San Diego, and that we have an emergency call at 9 o'clock because we may have unanticipated arrivals. And again, I'm going a little bit off script here, but
one of the challenges has been that my wonderful colleagues here who agreed to be on the schedule get, you know, I'm either calling them to say, we have too many people, does anybody not want to come? Or I'm calling them in a panic to say, we've got 270 people coming tonight. ICE is releasing this huge number. One week we saw well over 1,000 people in from Monday to Friday. And I need you to come in. I'm desperate. I need you to come in. And so for the last 3 days, we've been calling people and saying numbers are down. It looks like people are still being sent back to Mexico. And as of 5 minutes ago, when I just got, we just, you know, we may have this huge surge of probably pretty.
Flying in from Texas. How do they
This was
get away with
Lucy
that?
heard it in the news. Lucy heard it in the news.
I heard it on NPR while I was driving here.
You know? We have really good county supervisors, at least
Now.
saying about this project.
Yeah.
They really,
Yeah.
you know, let go of the money for the project. Yeah. What a bunch of wimps, you know? Why didn't they keep them there?
So the county's been,
There's a lot of people there.
so the county has been keeping track of all of the clinical findings and reportable diseases in the shelter. And, you know, overall, you know, we have a lot of lice, 681 cases in total, scabies, 354, but pretty low numbers of other concerning communicable diseases. And I think if you would ask people when the project started what they would have expected to see, I think people would have expected a lot more. So there's, none of the rule out TBs actually had TB. So that's pretty important. And so you look at, you know, these people are coming in, they've been traveling for months. The conditions have been horrible, but they're actually not like that sick. They have a lot of colds and they're kind of run down, but they're not bringing in diseases of public health concern. And I'll just note that the majority of the emergency department referrals were for chest x-rays, and that was before a protocol was developed in which guests are isolated offsite and then can receive a chest x-ray at the county TB control in the morning. But prior to that, they had to go to the ER. So the ER referrals have dropped a lot since that protocol was implemented. Some other conditions that we see, pregnancy complications and women actually in labor. A lot of skin issues like lacerations, skin wounds, burns from barbed wire and electric fences that are encountered when crossing the border. Fractures and other injuries related to crossing the border wall, and actually injuries sustained from falls off the wall. Dermatitis, skin ulcers, UTIs, pinworm. So as I think Linda will mention some of the main challenges that we kind of already discussed.
Yeah, I think most of them have already come up. One of the reasons that we're seeing some of the border wall injuries and lacerations from barbed wire is not everybody comes to the port of entry and presents themselves and says, I'm an asylum seeker. Some people try to enter the country and then hope to get actually identified by Border Patrol. So every day we get WhatsApped by ICE and Border Patrol to tell the group of us how many people are arriving. Those are sometimes accurate and sometimes not. The times of arrivals are almost never accurate. Last night Lucy was on, and we were supposed to get 87 people at 4 o'clock, and the last people arrived at, not 40 people arrived at 9:30. I mean, it's very hard to plan and staff around that level of uncertainty and not finding out how many people are coming to a clinic until sometimes even the clinic's already started and you're doing your best. So we have to have people on call and so on. I mean, I've run a lot of systems. I ran the health center where Mary and I worked for 21 years, and then have run the residency and the refugee, and I've never dealt with this this level of fluctuation. Even an emergency room has a more predictable flow, you know, ebb and flow. It might just be you have your bad days, but you kind of say Friday nights I staff up and Monday mornings aren't so bad, you know, this kind of thing. We've already talked about the communication from ICE. The other thing that's been unpredictable is that even though we have this whole system set up and that ICE is supposed to bring people from their detention facility to the shelter, that's still not always happening. And sometimes people are still being dropped off. So it wasn't that long ago that I was at my clinic and I get a phone call from JFS saying that ICE had dropped off somebody in labor at McDonald's. So, you know, and then the decision is, do you call 911 or, you know, could JFS safely transport them? So they're, you know, trying to decide how far are they in labor. It turns out, you know, their water hadn't broke, their contractions were only 10 minutes apart. I'm like, okay, I think you can safely get them there because it's traumatic to have the fire department show up and so on. And the other issue is kind of the unpredictability of things. So we've been doing, it's outside of the scope of our mandate, but there's nobody else to do this. When people get isolated, they get sent to a hotel 2 blocks from the shelter. Then just a little FYI, there's probably a couple hotels you want to stay away from. Just saying. So we've been doing home visits, house calls on these people who have been isolated, and so things come it's kind of unexpected things come up. So yesterday Lucy kindly went and did a hotel visit on somebody, the family of a 17-year-old been diagnosed with chickenpox over the weekend, sent to the ER because he was very ill, get put on a cyclovir, and the mother and the child, the sibling, got vaccinated. The mother still went on to get chickenpox, and Lucy had her sent to the emergency room, which means JFS had to send a babysitter to the hotel because we didn't want to leave 2 minor children alone in a hotel, one of whom was a very miserable 17-year-old. So it's pretty much every day there you have these protocols in place, but something unusual is happening, like in 4 minutes, we're going to find out how many people are being flown in from Texas.
So we'll try to wrap up quickly.
Yes, sorry.
So yeah, just to summarize some of the lesson learned, you know, the unpredictability requires extreme flexibility of staffing and other needs. The continually evolving protocols and practices requires ongoing provider education and communication, especially because some providers only come once in a while, and so they need to be updated on what's changed since they were there. Something that's actually really interesting is the language and translation issues. I think, you know, we would assume that pretty much it's Spanish speakers that are coming through, but there's actually a lot of non-Spanish speakers. There's a pretty decent number of Vietnamese asylum seekers that have been presenting, and as well as Haitians who speak Creole. And then the Mayan indigenous languages have been presenting a pretty big challenge. So these include languages like Quiche, Kanjobal, Mam, and Chuch. And if you try to use a translator line, they will tell you, oh, that's not a language. So these indigenous languages, it's actually a really big challenge nationally. Because there's very few trained interpreters, particularly in a medical setting, for these languages. So sometimes we will use another guest who speaks Spanish and one of the languages. There's a few interpreters that are contracted by HANA who just happen to speak the language because they grew up in one of these regions. But you know, sometimes it's the language is pretty limited. But some of the, you know, positives have been the unexpected educational opportunities for all the med students, nurse and NP students who've been shadowing in the clinic, all the residents, even pre-med student volunteers who help out as, you know, patient transporters, et cetera. And there's been some, research and QI scholarly activities that have come out of this project. Challenges ahead, the current political situation is highly volatile. It's evolving even this morning about whether people are going to be waiting in Mexico for their hearings sent here. I just heard on NPR this morning that they're going to start sending people from Texas to ports of entry in South Florida to be processed, and that's causing a lot of backlash and drama because they're completely unprepared there to deal with the situation. And it's estimated that in the next couple years, 350,000 immigrants from the Northern Triangle countries are going to lose their legal right to live and work in the U.S. because their temporary status could be revoked. So where will they go is unclear. They returned home, it could be dangerous and a death sentence. And we just wanted to note that there's a lot more organizations all across the San Diego County that are involved in the care of asylum seekers, not just the Rapid Response Network and UCSD. There's the Christ Ministries Safe Harbors Network. They provide free medical care from USD-SDSU. There's a UCSD student-run free clinic. There's the Medical Missions run by Mark Alcott, who provides medical care for CBP. There's programs all across the U.S.-Mexico border, from California to Texas, who are responding to this humanitarian crisis. And there's thousands of migrants still in Tijuana. And there's a medical volunteer group from Southern California, and it's run by Phil Canete, who's an amazing pre-med student, and the San Diego Border Dreamers. And they cross the border every weekend to visit shelters and provide medical care there. And they're a completely grassroots organization. So in conclusion, the experiences show how a coordinated and cooperative response to a humanitarian crisis was successful in meeting the needs of the asylum seekers, Jewish Family Services, and the community by bringing together multiple agencies with unique skills and expertise to contribute. But there's still a need for a sustainable long-term solution to this ongoing crisis, not just in San Diego, but all across the US-Mexico border. And so here's the main partners that have been involved in the project. And then I'll just leave with this slide, which a lot of people ask, how can they help? So, donations are always really appreciated, both physical and financial, and volunteers are always welcome. And if anyone's interested in, learning more, they can contact one of us or contact JFS and get put on a volunteer list. So thank you guys so much for being here today. I know we're running over, but we probably can take a couple questions.
I do have one statement, and that is California is the 5th largest economy in the world alone. So God bless you, and I hope we can get organized, because there must be a CBP process, there must be an ICE process, and then they're coming to you. And apparently within our own 2-mile region, we can't communicate with each other. So God bless you. Thank you very, very much, from someone who's lived and raised children in California, and we're behind you all the way.
Well, definitely has been an incredible group effort, and people like Lucy and Joe and Camila and the others and the ID department have been absolutely indispensable.